And that's the 70 to 600?
70 to 600, correct, yep.
Okay.
So even if your tidal volume's less than that?
Yeah, so it's a good question. I'm not sure.
So it's just not fitting
Hamilton
on
makes their lips wider so that they have to buy the specialty stuff.
That makes sense. Yeah, I'm sure we've encountered that problem before, but yeah, that's
Do you put an
interesting.
adapter in there?
You probably could put an adapter in there because you'd be after the flow sensor, but yeah, sorry, I should have checked that out ahead of time. I apologize. All right, so we're going to change our scenario and we're going to go to the pediatric HME. So we're going to assume that we have a tidal volume of say 70, just for the sake of the HME's preferences. So we're going to use this HME, pediatric HME on here. And if you want, which I suggest, you're going to use end-tidal CO2. And end-tidal CO2 is something that we always do with pediatric patients because we want to know when things happen with them, and things happen very quickly, especially with small endotracheal tubes. So I always recommend using end-tidal CO2. So I brought these blue adapters down as well. So these are specifically for infant neonate, and this will connect to your monitor. I believe your monitors have this already for the adult patients. So that would connect here. So again, we've had our patient come in, we have said that we're going to use 70 for a tidal volume, and so because we're assuming tidal volume, we're going to go with tidal volume, right? So we're going to use volume instead of pressure. So you're going to select SIMV, volume controlled, and 6 to 8 mLs per kilo. We said we're going to do the 70 for the tidal volume, so we're going to file that in. The recommended ranges for PEEP are 5 to 8. I always start low on kids, so I would always start at 5. FiO2, I would say FiO2 to get the desired SAT, so say greater than 92, 94. And then as far as flow trigger, the Hamilton starts out at 0.5 for a flow trigger, and I've always found that to be pretty good for the flow trigger. When you're talking about eye time, if you're going to be dealing with a neonate, you're going to be looking at 0.4 to 0.5. Our standard in our NICU is 0.4, just pretty much across the board, it's 0.4. If you have older kids, you're going to end up going with, if you have older kids, you're going to be going with 0.6 to 0.7. So we'll put it at 0.6 because we're seeing this is a bit of an older kid. Respiratory rate, you want to shoot for a respiratory rate that's going to match what that type of patient is. And we printed out a couple forms here, so there's a couple you guys can pass around if you want. But we want to shoot for a tidal or a respiratory rate that is going to be close to what they do. So what we put on the form is 20 to 40 as sort of like the range. Most kids that I see, unless it's an asthmatic, I'm going to start at 25 to 30. If it's an asthmatic patient, I'm going to start much lower. I tell people this all the time. Did you ever work with Dr. Eric Renaud?
Yes.
So he was a pediatric intensivist that worked at Maymed for a while. And he would tell every resident that ever came into the PICU that his rule for asthmatic patients was 10, 10, 10. So he did 10 mLs per kilo, 10 of PEEP, and 10 for a respiratory rate. And the reason I say this to all of you is I think 10 mLs per kilo is probably out of vogue. I would still stick with like the 6 to 8, probably go on that side of 8. But remembering that using a higher amount of PEEP than you normally would and using a low respiratory rate, the most important part, a low respiratory rate, is going to help you out. So in the absence of an asthmatic child, I'm starting at a respiratory rate of say 25 to 30. And again, we have our end-tidal CO2, so that's hopefully going to guide us. Pressure support, typically 5 to 10. So for this patient, we'll just go to 5, which is going to just be the amount above your P. Excuse me, the P limit is going to be the limit that's going to happen to volume or to cycle out of a breath. So if the volume you want to deliver is taking too much pressure, it's going to cycle out. Standard in pediatrics is 30 to 35, so it is lower than in adults. Now, if you have a child in there that you're not able to ventilate without doing that, and you've spoken to your physician team, you may be able to go up on that. But it's something that I would definitely have a discussion with your physician team about before you would increase it. So that's sort of initial settings. It's really kind of keeping it simple, 6 to 8 mLs per kilo, 5 to 8 on your PEEP, 20 to 40 on that respiratory rate, keeping in mind the condition the patient has, 5 to 10 for pressure support, and the eye times are right on here, and make sure to just kind of keep it simple. That's why, for me, I don't 0.4 to 0.5, I don't even use that, I just go 0.4. Kid, 0.6. I'm gonna go up a little bit if I need to, but I just kind of keep it simple and say this is always the numbers that I'm gonna be picking for this patient. And then you've now put your patient on, you're immediately looking to see what are your return volumes, what are your peak pressures, what's happening with the patient. Are they breathing way above me? Do they need to be sedated? Are they not breathing at all? Do I need to go up on my respiratory rate because they have a GCS of 3? They're not contributing at all to what we're doing. So keeping all those sort of factors in mind, it's not gonna be a set it and forget it, and especially with the kid, you're gonna put it on them, and as things change dynamically, you're gonna change with them. This is why the end-tidal CO2 is so incredibly important. We've talked to our PICU docs about it because this adapter is incredibly frustrating, especially on humidified circuits. You guys you probably will not have,
I'm sorry.
no worries. You probably won't have issues with this because on humidified circuits, you have the problem with rain out getting into the end-tidal CO2, and it makes it so that it just doesn't read very well. Sometimes if the patient has a lot of secretions, it'll get in there and it won't read very well. But having the end-tidal CO2 to help guide your decisions helps out a lot. So I would definitely get that on. Remember to document it right away and keep your eyes on it the whole time you have the patient there, because if there's a change there, there's almost certainly going to be a change in the patient. Speaking of which, if you have a patient with a uncuffed ET tube, you should always go and take a look at your leak when you get the patient on the ventilator, see what it is, and figure out if you have to make some adjustments. So if your leak is, say, 90%, that may be a function of the size of the ET tube. It may be too small for the patient, and that would be something to tell the team, especially early on, because you're trying to ventilate a child who is not able to ventilate themselves, and you're likely being very ineffective at a 90% leak. Now, say your leak is 20, and they move the baby to get, or the child to get an x-ray, and you look again, and now it's 80 or 90, well, maybe we should take a look at the ET tube. Is it still in the right place? We're gonna move it forward. The most simple of things, but we actually, the reason that we are now mandated to go to the cath lab for infants is because anesthesia was not paying attention to their leak one time, and they had a child who came back with like a 6.9 gas in the cath lab because they had this super high leak, and no one picked up on it until an RT came and said, well, the tube is basically out, you gotta push it in. So,
Is there an acceptable percentage of leak as long as you're getting their volume?
yeah, so I think in our NICU, typically you'll have kids with like say 20 to 30%. I mean, the reason that we put in uncuffed tubes in neonates is because they're gonna grow, right? So we accept that we're gonna put an ET tube, it's gonna be pretty tight at first, and then they're gonna grow, and then there's gonna be a leak, and we'll have to upsize the tubes as they go. Most pediatric patients should always get cuffed tubes. PICUs around the country want a cuffed ET tube unless there's some sort of tracheal reason to not have one. Say they have some sort of tracheal insufficiency for whatever reason, then they would put an uncuffed tube. But most of the time you're gonna have a cuffed tube, but it's so relevant to know, like, hey, if the leak changes, you've got a problem, pay attention to that. So.